Okay, we're live. Hi, this is Elliot Fishman. And for the first time in a long time, I'm actually working from home today. I have a number of abstracts and grants that are due, and I can't really do work like that at work. So I'm doing it at home, finishing up a new lecture for University of California, San Diego's meeting the end of October. Then I'm going to record that lecture, but a really expanded version for CTisus, and that'll be actually shown in September. I need to catch up a bit because we only have lectures for about 4 more weeks, but I'm giving a bunch of talks in October, and so I will be catching up with a whole bunch of new talks. We always, as you know, post a new talk on Monday. It's on YouTube, it's on Facebook, it's on the website, and we've had well over 1,000 talks, and I will have a bunch of new ones being generated, and we always are creating new stuff. On the stomach, so why did I pick that for today? I needed to pick something. That may be one answer, but I was reading some stuff, I guess this past weekend about the stomach. There was an article called Staging of Gastric Cancer, just was published in Radiographics. And so I read that article. There was nothing new. It's a well-written article. It does make several important points. One is that it focuses a lot on the protocols. 1,000 cc's gastric distension, mandatory. In fact, they do a non-contrast scan first. We don't, but they do to make sure the stomach's well distended. I can't argue with that, but you want to minimize radiation dose. We just give a lot of water, so we assume the stomach's going to be distended. We give 1,000 cc's with the last 250, 300 when the patient's on the table, about to get scanned. So that usually solves the problem. They do 4 phases. We do 2, arterial and venous. They do a delayed. They say it helps them a little bit in separating the submucosa and the gastric wall. That may be true, but again, we do try to limit the number of phases we get. They talk about some of the challenges, and they focused on gastric adenocarcinoma, the difficulty in picking up early lesions. They spoke about the CT appearance, particularly of early infiltrating tumors, and that's what they focused on. We'll have a talk, and I'll redo my talk on the stomach, just because we need to update it soon. But one of the things we also talk about are the different tumors. So gastric adenocarcinoma can be small, fundus through body and antrum of the stomach. You look for mucosal enhancement or breaks in mucosal enhancement, focal thickening or irregularity. You can see an ulcer at times. We then talk about lymphoma, where it's usually bulkier. Now, in the old days of CT, it was always said it was over 5 cm, it was lymphoma. We don't see so many 5 cm lymphomas anymore because we get CT earlier. So adenocarcinoma and lymphoma can look about the same, but we'll be very careful. Lymphoma obviously probably has more nodes, and surely the nodes with lymphoma go down beneath the renal hilum commonly, and nodes from gastric adenocarcinoma are more around the celiac, the gastrohepatic nodes. They're not as large. With gastric cancer, a node above 8 millimeters we call positive. We want to be very sensitive to those nodes. With lymphoma, you also will see liver lesions, so will you in adenocarcinoma. But with lymphoma, you're more apt to see spleen and renal involvement as well. We talk about GIST tumors, gastrointestinal stromal tumors. They're often large. Most commonly, they're exophytic in the stomach, but they can be intraluminal. They can be intraluminal and extraluminal. With GIST tumors, I always make the point the smaller ones tend to be very vascular. The larger ones commonly have ulcerations, but they're not as vascular. And that's true in the stomach, that's true in the small bowel, and it's true anywhere, esophagus or colon, where GIST tumors occur. GIST tumors, when they're small, are very vascular. We've spoken about this and how it can look like a carcinoid tumor. What else we think about in the stomach? We think about metastasis, right? You can get Mets, you can have duodenal cancer growing up, but we think about Mets and what Mets go to stomach. Melanoma is one good thing to think about. Number two, where's my hand? Number two to think about is renal cell carcinoma. With renal cell, the Mets are typically vascular. With melanoma, they're typically going to be hypovascular in nature. In terms of protocols and looking at the images, you need axials, coronals, and sagittals. 3D imaging can be very helpful. We've published some work, I believe, on cinematic rendering, and that can prove very useful as well. One of the things also we look at in terms of the stomach with adenocarcinoma is looking for implants on the mesentery and omentum. Remember, gastric cancer also can go to the ovary, the so-called Krukenberg tumors. So that's also something you will indeed look out for. Now, in terms of gastric cancer and recurrence, if things recur, it typically recurs locally. CT is pretty good for looking at recurrence. It's a little tricky, again, good distension, looking at the anastomosis. It is somewhat tricky. People have tried PET. PET can be helpful sometimes, but typically is not going to be all that helpful either. So again, it can be somewhat of a challenge. In terms of the stomach, we also know that it can be difficult to distinguish particularly early gastric cancer from infection or inflammation. We talk about gastritis, we talk about wall thickening. Gastritis can be anywhere in the stomach. You can see ulcerations, you can see areas of bleeding in the stomach. Again, it's a challenge, particularly when you have an ulcer and a perforation, to determine whether it's a perforated ulcer that's benign or malignant, and that's something we leave to endoscopy. So again, detection of disease will typically be followed by endoscopy and biopsy. So at times, when it's bulky, it's easy to say it's cancer. When it's not very bulky, you might be thinking inflammatory disease, but you can be fooled, and endoscopy is necessary rather. So that becomes very, very important. We talk about other inflammation in the stomach. I'll just mention air in the gastric wall. Gastric emphysema can occur, often due to a G-tube placement or a procedure. But then there's emphysematous gastritis, where there's air in the stomach and there's necrosis. You may see air in the portal vein, SMV, or any of the branches. Patients are typically very sick. You can see emphysematous gastritis with small bowel pneumatosis as well, when the patient has ischemia of both stomach and small bowel. So there are a range of possibilities in the stomach. Again, protocol is very critical. The combination of distension of the stomach with water, IV contrast, 5 cc's a second, multi-phase acquisition, and you do all of that, you'll do a great job. So let me just take a quick look. Is there anybody saying anything? I know there's 14 people here. Let me see, view insights. Anyone saying anything? Well, at least I can't see anyone saying anything. So if you have any questions, let us know. And I hope everybody has a great day. See you later.